Okay, it is my great pleasure to welcome you to Managing Hospice and Palliative Care Through the COVID Crisis. My name is Tabitha Rupel, and I'm the Director of Implementation and Training for HospiCorp, and I'll be your host today. I am joined today with our panelists. First, I'd like to start with Dr. Rebecca Bledsoe. She is the PharmD and Vice President of Pharmaceutical Care and Mission from Ohio's Hospice of Dayton. Rebecca, if you just want to say hello to everyone here.
Good afternoon. It's a pleasure to be here today, so thank you for inviting me.
Secondly, I have Dr. Robin Iverson. She's the Medical Director for Valley Hospice and Palliative Care for the Valley Health System from Paramus, New Jersey.
Hi, nice to see you all.
I have Carrie Short, the Executive Director of Hospice of Miami County, Troy, Ohio. And last but not least, I have Yusimi Sobrino Bonilla, the Advanced Nurse Practitioner. She is the Palliative Care Clinical Supervisor for the Valley Health System in New Jersey. Welcome. I wanted to share that we're in this unprecedented time, and we wanted to come together as a community. And our goal is to share information and experiences from the Hospice and Palliative Center programs who are sharing their experiences from the challenges they're facing from COVID and other crises. They've worked through these difficulties and have found solutions to provide really great care. Our panel desires to assist other organizations in preparation for COVID-19 or any other emergent situation that may arise. And they want to assist in any way that they can, answering questions and sharing best practices. We've already received many questions from clinicians when they signed up for the webinar. And I will interweave those questions throughout our conversations today. At the end of our webinar, we have resources provided to us by Opus Peace. We recognize the needs of the frontline staff and we commend them, and they are the true heroes today, providing care at the front line to our patients day in and day out. We want to ensure that they get the support that they need during this very trying time. We also have an exciting announcement that we will be sharing at the end of the session from Hospice, so please stay to the very end. We're very excited about that. So I'm going to start right off first with Dr. Iverson and ask you first, how did you prepare for this COVID-19 crisis? How did your hospice and palliative care program approach this?
Well, our palliative team and our hospice team work both in the facilities and outside. In the hospital itself, the palliative people were very proactive in getting their goals of care and post conversations going and getting the emergency department on speed with that. When the onslaught really hit, I don't think anybody was as prepared as we expected. It was not anything like we anticipated. The volume was much higher than we anticipated, I think. Once the patients began coming into the intensive care unit, the palliative people were right on top of them, making sure goals of care were being addressed and making sure that both the practitioners and the families were being supported, because that's the other big part of this, is the support of our staff itself. This has been draining, not just for families, but for the practitioners, from the doctors to the people answering the telephone. It's a very stressful environment. As far as the hospice, we've tried to keep patients in the facilities as opposed to sending nursing home patients to the emergency room, because it's very clear that elderly patients with comorbidities have a very poor trajectory of this illness. And to bring them into the hospital would not benefit them, but rather to treat them palliatively in the facilities would be the better way to go. And we've had good success with that. Within the hospital itself, there was a Saturday afternoon that both Yusimi and I were on the floor, and that's when we were notified that there were going to be medication shortages. And I think that's when we both had a light bulb go over our head and said that, you know, maybe we need to stop using intravenous medicine and let's start using the MACI catheter and start using some oral medicine rectally, as we've done very successfully in the facilities and in our homes with our hospice patients before any of this broke. That started a nice ball rolling with a good collaboration. We did not have the the MACI catheter protocol in the hospital prior to this. It was something we had wanted to do. They had wanted a lot of, you know, it was going to be a big red tape to get it through the hospital. And we figured, okay, we'll get it eventually. But in a time of crisis was the good time to strike. And Yusimi worked on a weekend, got that policy approved and instituted, and it has been working remarkably well for us.
Yusimi, can you share with us some of your experiences, because that's a huge change in practice. So how did you incorporate that into the hospital setting, and what are some of the challenges that you faced with the COVID patients and bed management and staffing?
So we have been working very closely with leadership throughout this whole entire process. And when we were notified, we in palliative care, we have the home-based, and we were looking to use the MACI catheter about a year ago. So I already had information, and our hospice has been using it. So that was helpful. And when I went to leadership, I said, you know, we have this ability to use the MACI catheter to help, one, to have better symptom management, because what we have been seeing is that our normal routine doses aren't necessarily managing the dyspnea that we are seeing in the COVID patients, and we've required higher doses. And two, to try to save the medications for the ICUs and places where you need to have the intravenous usage. And they were very open. I have to say, everybody has really just tried to be innovative and trying to get support in. And I provided the policy. I used hospice's policy plus what Hospice Care has, and we made it fit for the hospital. Of course, one of the barriers is that nobody was familiar with it. Nobody has used it. How do you train an entire nursing staff in a short period of time? And, you know, hospice did make themselves available as a resource if we needed it. Hospice Care made themselves available. We've used the videos. We've put them up on our palliative care webpage so that the nurses have access to it 24 hours a day if there are any questions. The palliative care team has made themselves available, and we used our unit-based clinical educators as a train the trainer. So we did an education session with them, and then they've been going out and training the nurses. And we've gotten some very positive feedback from the nurses. They like using the catheter. The symptoms have been well managed. And I did talk to our pharmacy today, and we have seen a decrease in the IV drips that we've been using. So that has allowed it to be used for the critical care patients. We have designated COVID units. Unfortunately, at this point, 70% of our hospital are COVID units. So we have very small amount of non-COVID patients. We have a designated ICU that's for non-COVID patients. We have 2 floors that are still non-COVID, but the rest of the hospital is COVID. The hospital also worked to make negative pressure units, and they're constantly doing, you know, further modifications.
Are you transferring any of your patients from the hospital setting or discharging them to the home setting or to your IPUs?
We have. So case management has been instrumental in working with either facilities, family members, and trying to get people home if they can. So that's really been the big push. And most recently, we've definitely now started to be able to get people back to their facilities if they were in long-term care. They are accepting them back. And then hospice has also been very helpful, because when people are hospice appropriate, if we can get them out of the hospital setting safely to home, then they've been transitioning to home as well.
Okay. Carrie, what are you seeing at Hospice of Miami with some of the challenges of caring for patients that have COVID and they're in the community setting? What is your organization doing to make sure that there is still a high level of care while meeting those needs of the family and also following the directives by the emergency management for your county and the CDC?
Hi, so we are seeing patients still in our extended care facilities as well as in our home care settings and assisted livings. We are working together with the hospital upon discharge planning to get these patients to the place that they would like to be at that time. We're equipping our team with the appropriate PPE as well as using some telehealth options to make in between, visits or on call when people are calling into triage for some help to be able to quickly see what's going on in the home or in the setting.
Are you able to utilize any other mechanisms to palliate those patients? Have you had to change your practice at all?
So fortunately for us here in Hospice Miami County and Ohio's Hospice, we had started using the Macy catheter over a year ago, more routinely for our patients that have symptom management needs. When there was that IV shortage a year or so ago, we implemented this protocol and order sets and things around that. So we have been able to continue to manage symptoms very well. We use the Macy catheter both in our inpatient unit, our extended care facilities, and our home care settings.
Now, Rebecca, I wanted to have you speak a little bit, since you're a pharmacist, about medication shortages. We're hearing a lot, it's been in the paper, about injectable shortages. And we've heard with the COVID patients that sometimes it takes up to 3 times the amount of medications to sedate the patients in the ICUs and to palliate if they are under hospice care. Can you share with us some of your experiences and what the best practices are at Hospice of Dayton?
Sure. Carrie had mentioned that we began using the Macy catheter a while ago, and it actually goes back to the shortage of 2016. In the fall of 2016, we saw shortages both due to the government limiting production as well as the hurricane that hit Puerto Rico. So at that time, we were facing shortages like we are now with pain management, with sedation. One that we didn't have at the time was the medications they used to intubate. So that is new, but very much similar to what we were seeing in 2016 with the pain management and the sedation. So what we did at that time and what we're continuing to do now is reduce our injectable usage. So at the time, I'm based out of a 52-bed unit in Dayton, Ohio. And at the time, probably 80% of our patients were receiving injectables if they were here in the hospice house. In 2016, if we had continued our current usage, we had about a 10-day supply of morphine and about a 2-week supply of hydromorphone. At that point, it became very apparent that we had to change practice, and we had to change practice quickly. So that's when we took on or went to the Macy catheter. We had to teach the nurses quickly. So within a week, we had a physician champion and Wendy Schmitz. We worked closely with our education department, and we trained our IPU staff as well as our staff both in home care and in long-term care. And what we found, we made the switch. We found that we could convert pretty much 1-to-1. Sometimes we have to go a little higher or a little lower, but when I say 1-to-1, it's oral to rectal. And then we also implemented them into our standing order sets, both in home care and in the IPU. So that certainly helped us then and is helping us now mitigate these shortages.
I did have a question that came up. Given the severe symptoms, what medications is your hospice using in response to severe air hunger, tachycardia, pain, and severe anxiety?
So we start with our standing orders, which are available through Hospice. If anybody would like to see those order sets, we start there. And then we titrate as needed for symptom management. We very much go on a case-by-case basis. So for pain, we center around using morphine, hydromorphone, and methadone. For shortness of breath, we typically use morphine and Ativan. For anxiety, we use Ativan. We do have others. We can use diazepam as well as midazolam. For agitation, we tend to use Haldol, although the more severe it gets, we will add on phenobarbital as well as Seroquel. They both absorb very well through the rectum. And then for tachycardia, we tend to use a beta blocker. Our go-to tends to be metoprolol.
And then the last question was about ketamine, utilizing ketamine for extreme cases. Can you speak a little bit about that?
Yes, we use ketamine as well. Usually we base it off the dosage that the patient is receiving. Generally, we found that it tends to be a little more potent via the rectal route. So we can cut back on dosing. Then we usually give it every 4 hours routinely around the clock, and then add a PRN dose as well, usually every 2.
And then Carrie, can you talk a little bit about how your home program is dealing with caring for patients in place and getting the needed clinicians, medications, and fluids to patients when hospitalization is not an option?
Sure. So some patients don't want to go back to the hospital for a variety of reasons, and they do want to stay in their homes. And that is really our goal, is to keep people where they are and where they're most comfortable. So we do contract and are able to obtain IV fluids from a vendor. We are able to give those via the Macy catheter if needed, as well as medications in the home. So what we do is we teach the patient or the family to be able to give the Macy medications via the Macy catheter during our routine visits, and then we can check in as well with our telehealth visits in between those times.
Can you tell us a little bit more about your telehealth visits? Because with everything that's changing now, everybody's working from home and there's social distancing. Can you share with the group how your telemedicine is set up and how you're treating your patients in that way? Does it include all disciplines, or is it just mainly the medicine portion of it?
So the telehealth visits include all disciplines, social workers, chaplains, nurses as well. So we have a vendor that we use for our telehealth. So we're able to just contact families, and they are able to hold their phone, and we can visualize the patient and their current situation, or have, conferences or phone calls for prayer and those kinds of things via those telehealth routes. Of course, asking and making sure that the family is able to use these devices up front is important. And we have an algorithm that we are using, and we are doing this upon admission of new patients.
Thank you. I have another question that came up, and this could be for Yusimi or Dr. Iverson. What are the best practices for psychosocial in the hospital setting to support the patients that are in crises, that are in the hospital, because the level of fear and not knowing what their outcomes are going to be? Have you instituted anything to help in that regard?
We do have our social worker, so we have a palliative care social worker. She is still making phone calls, and we are doing visits as possible. What we have noticed is that unfortunately a lot of these patients are not very awake and alert. They're confused, disoriented, pretty much delirious. But what we did do is every unit has an iPad, and we have the ability to try to contact family through different apps, depending on what the families have available, to set up what we call telefamily visits, so that the patients can still see their loved ones, and sometimes just hearing their voice, you could see it, them perk up or open their eyes. And I think that that's been so instrumental for not just the patients and their families, for the nurses, because everybody does feel awful that the families can't be here during this difficult time. And they were originally using their own devices, and now they can do that. We do have a nurse and a social worker who's also calling the families and giving daily updates so that they have information as well about how the patient is doing. And everybody's just trying to keep up with them so that they feel supported.
What about the staff? We hear so much about the staff, their stress levels, and the staff getting sick. Have you instituted anything in Paramus for the frontline staff or some sort of support, or what have you put in place to make sure that everyone is protected and their spirits are uplifted?
So we have a great integrative healing team, and they've been doing daily intentions. And overhead, we do the daily intent. They'll do the daily intentions. They've been going around with aromatherapy for the nurses. We do have also like a crisis support system, and they've also started to do telehealth crisis intervention, where they've set up where the people can call in and talk about what's happening to help feel supported. The nurses have also, whatever ideas they've been putting or thought of, they've been put into place to try to help support them. We now are also, every time a COVID patient gets discharged, they do a little jingle of homeward bound. So that's also uplifting to the nurses to know that people are going home. And we have signs everywhere about how many patients are going home every day, to kind of say, listen, the work that you're doing matters. It's making a difference. And I think, again, the iPad and those types of things have been great for them.
Wow. Dr. Iverson, looking back now, in retrospect, for hindsight's always 2020, knowing what you know now, and you're really on the epicenter area there, and many organizations are projected to be seeing new COVID patients coming to their area. What are some things that you could suggest, or lessons learned, or pieces of advice that you would offer to them, that if they are not already ready to have these patients come into their organization, what are some things that you would recommend that they do?
I think one of the things that a hospice could do to prepare is to prepare your facilities for what may happen, because a large onslaught of the patients did come from facilities. And as I said earlier, the trajectory of disease for these patients that are in their 80s with comorbidities is very, very grim. Keeping them in their facility is a better choice. Getting the facilities to be prepared and to anticipate that they are going to need a fair amount of PPE, that they are going to need some medications on the ready. Because I think that if you could keep some of those patients out of the hospital, a large number of the deaths that we saw would be diminished, at least in the hospital. I think the big stressor that I noticed in the hospital in the first couple of weeks were that now we've mobilized all kinds of units to take care of COVID patients, levels of caretakers that are not used to people who are on the brink of death, rapid death. Mm-hmm. The oncology floor nurses did a really good job, were well able to manage this, because not only had they been trained, they also have, resources to support themselves. When you take a orthopedic nurse and give her a patient who comes in and dies in 18 hours, this is very, very troubling to them, and you could feel their stress level was elevated. So I think the other thing a hospital can do is prepare their staff for the profound severity of this disease. I don't think any of us were prepared for how quickly they can turn and how horribly they can go down. I think if those things are in the forefront for the staff, it's going to be a little bit easier for them. It's been lovely to see the camaraderie that desperate times have drawn in our hospital. Our facility now is all for one, one for all. It's wonderful to see how everyone has mobilized. But if we could have been a little bit more prepared and kept more people out of the hospital itself, I think we would have been in a little better shape. Other things that can be done in preparation are, again, looking at your medication protocols and having them pat and set before this occurs.
What did you do as far as protocols did you change protocols during this time? Did you come up with new processes?
One of the things we did for at least our facility patients were, if a patient was COVID, we instituted around-the-clock medications for them so that lots of decisions don't have to be made, that the nurses can medicate and move on. When people are really sick, it's really hard to decide, is this mild to moderate dyspnea or is this moderate to severe dyspnea? Let's just make it easier and give them some standing doses of medicine, and that seemed to have been very effective at first, especially in the first 24 to 40 hours of some of these facility patients. Within the hospital itself, we do have some protocols that we've put in place. The protocols for comfort care have been established. They were then transitioned to the MACI catheter, as you see me said earlier, and they've been very effective. You can actually put somebody on essentially a morphine drip through a MACI catheter with regular dosing. You can titrate them up, you can titrate them down. It's really rather remarkable how easily that works and how adaptable the staff has been to it.
Very good. Go ahead.
I wanted to mention as well that in the process of all of this, we were having some difficulty with IV access, and our PIC teams, once they found out that we were using the MACI catheter, then they have been almost triaging, and if somebody is comfort care and they were getting IV doses, they'll call us and say, listen, how about a MACI catheter for this patient? Very quickly, they've adapted this very quickly.
Yeah. And the great thing about the MACI catheter is all you need is tap water. You don't even need IV fluids. So it reserves the IV fluids for the ICU patients, and then the patients out on the floor under comfort measures can utilize the tap water for hydration as well. So a question came up. Would you be would you be willing to share the algorithm about telehealth? We currently don't use telehealth, but have access to some units through our partnership with our home health agency. So that question, I believe, is to you, Carrie.
Yes, it is. And I can send that information through Hospice and they can put that out. Yes.
Disseminate that out. As far as medications, Rebecca, there was a question that came up. Are there any limitations of the types of medications that cannot be given by the MACI catheter?
There are. Some of those medications are any long-acting medication. You would need to go to the immediate release versus long-acting. Some of the NIOSH hazardous medications that shouldn't be crushed, therefore can't be given via MACI. And then there are 5 medications that just don't absorb very well from the rectal cavity, and that includes Neurontin, Triliptal, glycopyrrolate, baclofen, and Dilantin are the 5.
And then another question came in on our live Q&A here. So if anybody is interested in having a question asked, if you go down, you can type that in under Q&A on Zoom. The question is, what are the dosing changes with the catheter from oral to rectal? Is there dosing changes that need to be made, or is it a one-to-one for all?
It depends on what the medication is. Sometimes the medication doses actually go down because via the rectal route, they're bypassing the hepatic metabolism. So the dose may go down. Other times it may go up. So a great resource is actually one that comes from Hospice, where it's done an aggregate of the available literature, and it will say how the dose should be adjusted. Also, another great reference is put out by Optum Pharmacy. It does a little less than the dosing, but it says what medications. It's a more comprehensive list of medications that can be given rectally.
The next question, and this could be to anyone who wants to answer this. How hard was it to change practice at your facility? What were some of the barriers that you saw? So we can ask each one of you, you know, did you have particular staff members that were barriers? Was there a barrier to obtaining the product? So why don't we actually start with you, Rebecca, since you're up, and see if there was any. We'll start with Dayton.
Sounds great. Really, the whole team was on board because we were facing the shortage at the time. So we encountered very little resistance. And then what helped us is once we did implement the MACI catheter, the staff began to see that we were rotating to other opioids less often. And then also we were titrating less often, and we were seeing our patients were more comfortable using meds via the MACI catheter. So that was a huge incentive for our staff. And we've done post surveys, and we have a 90% rate from nurses where they're pleased that we've made the switch.
Oh, that's awesome. Carrie, would you like to share in the home and in the SNFs and the ALRs, were there any pushback from the staff members at any facilities or in the home setting or with families?
Sure. So initially, families were a little reluctant, just weren't sure, and patients just not sure and didn't quite understand the change. Once educated and you explain and show them and things like that, they tended to get on board pretty quickly. With our partner facilities, I would say, you know, just making sure that they had a policy. We had to kind of go through that with them so that their staff, if they were going to be utilizing this, they also had to have their own policies in place for this. So that took a little bit of time for some of them. Of course, this was a few years back, not in current conditions and things, but everyone really did get on board pretty quickly after the education and the why was provided. I think the why was important to staff, and then they got on board, and they do, just as Rebecca said, have really promoted this and seen the positive effects.
Dr. Iverson, and you see me, I'm going to ask from the hospital aspect. I know we touched on it. Did you have any hiccups? Because how you implemented it was with a short turnaround time and a large group of people. So why don't you share, you know, you shared about how you did train the trainer. After it was implemented, did you see any pushback or were there any concerns raised either by patients, their families, or staff?
This is the quickest implementation of any product I've ever seen happen. Everybody is so cognizant of the distress that these families, patients are suffering, that they want anything that would help them, and they've really adapted to the catheter. At this point, if I go anywhere, they know that we're going to be using the MACI catheter. Nurses are willing to help other people who haven't seen it or been involved with it yet. So I have to say I haven't really had any barriers. Right now, we originally had this approved for comfort care patients, those people at the end of life. And right now we're actually trying to move and change the policy a little bit that we can use it for any patient. So everybody's been really, really open to using the catheter. So I can't really say I've had any major barriers.
Wonderful. I have another question that came up on chat. In hospice inpatient units, are patients still eligible for GIP level of care when all medications are administered via the MACI catheter?
Yes, they are. That's been our go-to for a lot of our GIP patients because it's much faster to place the catheter. There's no IV fluids have to run to keep the line open. It's charming. It's just the best.
Perfect. Okay. Let's see. It says, can you walk us through what it looks like, how to obtain, and let's see, it says, can you walk us through what it looks like, how to obtain, and who trains to use, and exactly how it works? Are hospices familiar? Do you have to be on hospice care to utilize a MACI catheter?
No, the patients that are receiving the MACI catheter in the hospital right now, they're not hospice patients, they're comfort care patients. That doesn't mean that they're hospice admitted. We've been using it to give them their medications, again, not using intravenous. They're not hospice, don't have to be.
Right. And I can share that if a hospice is interested in learning more about the MACI catheter, they can reach out to us through our either our clinical line or go on macicatheter.com, and we can reach out to you as well and share how you can bring this catheter. We can onboard it to your facility pretty seamlessly. Let's see. Due to facility lockdowns, elaborate a little bit more what a chaplain can do. So, whomever would like to take on that question, I don't know, Carrie or you see me. Carrie, do you want to share what your chaplains are doing?
Yeah, sure. So our chaplains are visiting the facility patients, even though they're on lockdown, if the facility will allow them to come in, of course. But if the patient is actively dying and the family would like a clergy or a chaplain, you know, someone to come for their spiritual reasons, the facilities, a lot of them have been understanding of that. And we've been able to go. They maintain the proper distancing and wear the appropriate PPE if needed to see those patients and provide spiritual support. Otherwise, they are able to use telehealth to do those visits with the facility staff and the patient.
And then for the inpatient hospice, either in the hospital or in GIP in a freestanding IPU, what are your staffing ratios for an inpatient hospice unit during the COVID surge?
We have 2 advanced practice nurses in the facility, in the hospital all the time, with myself and a nurse liaison who helps transition patients from the acute setting to the hospice GIP level of care. And we don't usually have more than 6 GIP patients in the hospital at any one time, but that's daily. So our census at the end of the week can be, you know, it accumulates, but we never keep more than 6 beds full.
Okay. And then the next question that has come up is, how has the COVID impacted your hospice and palliative care programs processes, and what did you implement to mitigate these challenges? It seems to be talking about IDT, how you're able to do IDT because of the volume of patients and the deaths. How have you changed your practices, whether it's in the hospital or in the community setting or in the IPUs?
Well,
There's a lot of deaths.
Yeah, we do IDG on 2 days a week. Typically it runs 2 hours. Lately it's been running 2.5 hours. What we've tried to do is get each presentation very succinct. Unfortunately, there's not as much conversation. You know, there's always those conversations about, oh, he's so cute, he's the cutest little old man I've ever seen. And we've been cutting back on a lot of that because it kind of, you know, it's eating up our time. Today I did 40 admissions to hospice, and we had 37 deaths. So it was we tried to couple talking about the death when we talked about the case itself, as opposed to doing them as 2 separate parts of the meeting.
So you had 40 admissions and 37 deaths.
Yes, and the people who are surviving are the cancer patients, which is even more surprising.
Wow.
Yeah.
Do you have any insight to why that may be?
I think the COVID patients just get so sick so fast and die. So some of our turnarounds on those patients, we're admitting them at noon and they've died by 8 o'clock. And they were able to speak at noon and they've died by 8 o'clock. It's mind-boggling how rapid they go down. And the patients who have cancer and at home and their families didn't go out of the house and kept them without any exposure, they're the ones that are surviving because they're just still have their cancer. That's all they have.
Right. Wow.
For the inpatient setting, we have made all our IDTs virtual, so nobody is really getting together. And a lot of what we're doing is really trying to support each other. We understand that just the trajectory of the illness is very difficult to deal with. The families, as we speak to them, their struggles, and so we're really trying to be more supportive. The discussions about the patients, unfortunately, they're all relatively the same because the symptoms and how they present are the same. So we're not really necessarily going through each patient individually, but instead dealing with major concerns. If there's been a problem with a family member, a problem with the patient, we didn't have good symptom management, things along those lines. So we have had to change our process. We've had to increase staff during different times of the week. We cover 7 days a week, but our volumes are much higher. Our consults have increased 128%.
Wow.
And so we're really just trying to keep up with the volume.
Wow. That's intense.
I think the other thing that makes some of the patient conversations difficult when they're the COVID patient is that for many families, this patient was elderly, may have been a little demented, but wasn't otherwise ill.
Mm-hmm.
And now they come down with this disease that takes them down so quickly that there's not even enough time to get a family's head around how rapid this is going to go. So those supportive conversations that our social workers are having with the families are much harder because they just keep saying, but he just had dinner with us on Tuesday.
Right.
And it's Thursday and we're talking about him being ready to pass. So I think that extra added difficulty is stressing a lot of the support staff.
The other thing too is that these are families that are being affected where mom and dad are dying within a week of each other. You know, people are losing multiple family members within days of each other. And it's really, really traumatic for them. So I know that with hospice, palliative care is working to try to set up a support for all of these COVID patients moving forward so that we can set something up, because we know that once all of this is said and done, all of these people are going to need continued support, whether they were able to get onto hospice or not.
Now, I know you're still in the thick of it. Or do you feel that you're on the downside? Have you seen it plateau off, or are you still seeing those numbers climb in your area?
They still have us projected that this would be our big surge week. It's hard to, this is the kind of thing where you never want to say, oh yeah, it looks like it's getting better. Because as soon as you do that, it's like you never say, oh, it's been a quiet night when you work in the ER. So we don't go there.
Exactly. Wow. Well, we really appreciate you taking your time out and sharing your experiences with others throughout the United States who haven't gotten to that point yet and hopefully do not get to that point. So thank you. Rebecca, a question came in, and the question is there a list? All of those medications that you listed off, I had several Q questions. Can she list the 5th drug that you can't give? Can she list the 3rd drug? Is there a list somewhere of do not give via the Macy catheter?
I believe it's included in the Macy literature, but I'm happy to repeat those again if that's helpful.
Why don't I have you repeat it if you have it in front of you?
Sounds good. So the 5 medications that can't be given via the Macy catheter due to poor absorption, it's Neurontin, Trileptal, glycopyrrolate, orobenol, baclofen, and dilantin.
And the next question after that is, are there therapeutic interchanges that could meet the needs those drugs would have supplied for the patient?
Of those 5 medications?
Of those, is there something that could be given in lieu?
Yes. Yeah, reviewing the list of medications that can be given, one that we often give in place of both Neurontin and Trileptal is we use methadone if there's a neuropathic component. So we find that tends to cover the neuropathy. For the glycopyrrolate, we usually give Levsin rectally for our anticholinergic to help with the secretions. The baclofen has a couple of the other muscle relaxants can be given via the rectal route. I'd have to look to double check which ones. And then Dilantin, we use Keppra generally, and we don't use the tablet or capsule, we use the liquid, the oral liquid.
And at Hospice, we provide a list of those medications as well. But for those of you that this is your first experience hearing about the catheter under these circumstances, thank you, Rebecca, for sharing that information with us. So let me see if we have any other questions here. A specific question regarding hydromorphone appears rectal of bioavailability is 50% of oral. In practice, are you increasing dose when switching from oral?
Yes, we typically do, and then we'll adjust depending on the patient's clinical picture.
All right, and then I talked with Dr. Iverson and Yusimi. Do you have any lessons learned, Rebecca, that you would like to share with the group moving forward, knowing what you know about emergency management for hospices and medication management? Is there anything, any advice that you would give to those that are waiting to prepare or preparing right now?
I think one of the crucial things that we had in place was having a physician champion. With that champion, it seemed to help with everything else falling in line. Other than that, from a medication standpoint, some of the things that we found, like the phenobarbital, like one tablet, the roughly 30 milligrams, we found was roughly equivalent to Ativan 1 milligram. So that may be helpful making those adjustments. Trying to think if there's anything else. Seroquel. We found the combination of Seroquel and phenobarbital to be very, very helpful. And Seroquel is one where it has a pretty high maximum dose of 1,200 milligrams a day. So that's one of our go-tos as well for agitation.
Wonderful. And Carrie, what about from your standpoint, for those who haven't had COVID patients, any recommendations from your organization as an executive director? What would be your first step in preparing for emergency management?
I think the leadership team, we have a COVID task force, and we meet every morning via telephone calls, things like that. And just talking to them daily and then communicating with staff routinely. There's a lot of anxiety with staff out there and COVID patients and caring for COVID patients, things like that. We also offered what we called Cope and Hope, but it was kind of like a session that people could call into and just talk about patients or talk about their stories a little bit to relieve some anxiety. So just providing that sense of calm to the staff and your team so they can continue to provide the best care out there in the field.
Okay, let me see if there's anything else. All right, the last question we're going to take for today is share a little bit about ways in which we can support families to have a time for closure. Today, family is aware that funeral services are not the same, so they need some time for closure. I believe that Yusimi, you shared about the iPads and connecting with the patients on your unit. Does anybody want to share some ideas of what they're doing at their organizations?
Sure, I can share a couple of things. One thing that we have recognized is that there's going to be some trauma when all of this is over with patients and families, and definitely our bereavement department and team is working hard on how to improve services, how to connect with people whether it via in person later or via telehealth now, with families and things that are grieving as well. So, and for our COVID patients, we are allowing one family member at the bedside with these patients to have that closure, and providing, there are family members at a variety of locations in our area anyways that are going to the windows of like our contracted facilities, extended care facilities that are looking and talking, and the staff are really helping navigate that as well.
Mm. That's beautiful. It's a tough time. I've seen that ICUs have been putting together kits with fingerprints, making fingerprint butterflies, and taking lab bottles and the rhythm strip, the heart rhythm strip, and putting them in there. And people are getting very, very creative and providing something to the family, especially if they cannot be with their loved one when they pass. And they're writing little notes as far as who was with them, because the fear is that they're passing by themselves. So I think there are lots of stories out there. We just have to collect them so that we can share those best practices or whatever works for each of our organizations to take on and help provide that closure for the family. So, well, we've got 5 minutes left of our webinar, and I want to thank each and every one of you for sharing your expertise. I'm sure many have garnered some new ideas and plans to update their approaches regarding COVID and emergency management in general. I'm sure as healthcare providers, you may, after this event, look back at your emergency management plans and make some changes or updates, but that's going to be down the line. So thank you for your expertise. I am going to share at this time some information with the group, if I can here. Deborah Grassman, if any of you have ever listened to her speak, she is a lovely speaker, and she's the founder of Opus Peace. And they reached out to us last week, and they're a nonprofit organization, and they're providing some resources for staff. The first one is releasing fear, loss, helplessness, and there is a YouTube on that. So staff, if they want to go home, you could take your phones now if you want, and take a screenshot of this for your phones. And the second one is anchoring the heart technique. It's a self-help resource that they provide to lower anxiety. But I recommend that you go on opuspeace.org, and we're very grateful to Deborah Grassman for reaching out to provide that resource to staff as a whole. I think everyone can benefit. The next item that we're really excited about is that we have a Macy Catheter community page. This is brand new. For those of you that know Betsy and I, you'll see our pictures right here. It's up and running today. We will be posting some information, some of the Deborah Grassman information and links on there. And it's an opportunity, it's a closed Facebook group for people to share experiences and communicate, and just have that community sense to share. They need a safe place. Sometimes the general Facebook area, it's exposed to your family and whatnot. This is a community for those clinicians that want to keep it more private, but get updates on new information and new practices and upcoming webinars and whatnot. So please go on Facebook if you would like, and just type in Macy Catheter Community, and you will, the admin will invite you on, approve the invitation. So we're very excited about that. So we're at 3 o'clock now. I want to thank everyone. We are taping this program, so for those who missed it, there will be a replay on macycatheter.com under our webinars, under the clinical corner. I want to thank each and every one of you for joining us today. Thank you, ladies. Have a good day.
Thank you.
Thank you.
Thank you. That was fun.
Yes, thank you very much for having us. I really appreciate it. And I appreciate all the support I've gotten. Anytime I sent an email, Betsy answers me right away.
That's wonderful. That's
Thank you.
good to hear. There's lots of resources out there.
Absolutely. So thank you very much.
All right.
Thanks, everyone.
Thank you.